All right, welcome back, everyone. I am excited to introduce a young man who I've had a decade-long friendship with, and someone that I've always turned to for any and all kind of questions that I may have surrounding physical therapy. Dr. Dennis Valdez has been a professor in the Health and Physical Education faculty at Mount Royal University since 2009. He mainly teaches athletic therapy courses, but has also taught courses in personal fitness training program. In addition, Dr. Valdez runs an athletic therapy clinical practice where he treats patients with chronic pain and injuries and periodically delivers courses, webinars, and conference presentations. Welcome, Dr. Valdez, and thank you for jumping on board with this mini-series of mine where I hope to share valuable information to people of all walks of life. Okay, so let's start by telling the audience about your business sports icon, just because it will cover such a broad topic of focuses we're going to be diving into with different types of physical therapies.
For sure. So Sport Icon was a brainchild from way back in the day. This was in 1999, where upon graduating from York University in Toronto in the athletic therapy program, like all new grads, you're thinking about what am I going to do next? So I was like, well, I want to open up a clinic, but I wonder what this would be called, and try to come up with a cool little lingo title for it. So Sport Injury Consulting initially, what it was named. But then I shortened it to Sport Icon, and I kind of thought that had a little bit of a better twist to it. And it was really just delivering athletic therapy services. So anyone that gets hurt, twist your ankle, hurt your shoulder, hurt your back, they would come in and see me. And initially I didn't have a clinic because right out of school you don't have any money. So then you treat friends and family, you put your table in your car, you drive to their house, you set it up, and then you treat patients and so on and so forth. So I did that probably for about 2 years. So I tucked that away for like 10 years because then I went to grad school, ended up working in the United States in Florida for about 5 or 6 years, left, came back to Canada because I was missing home so much, and then started teaching here at Mount Royal. And then as I'm teaching, I'm like, it's one thing to teach the stuff, but it had been a while since I practiced and had my hands on patients and like actually doing it. And so I think it brought a little bit more information from an experience standpoint into the classroom when I was teaching to tell students about theory, but then how it applied in actual practice. And so I rejuvenated Sport Injury Consulting, Sport Icon, got my trade name, opened up the business, and then that evolved into trying to open up a clinic right before COVID. Gladly didn't open it because it probably wouldn't have worked. But then as soon as COVID ended, I ended up getting a space down here in Calgary with a friend of mine. So I treat patients outside of the classroom still, and I still bring those experiences to the students.
That's
so
amazing.
That's where it is now.
So what kind of treatments and therapies or techniques do you do with some of these clients of yours?
So generally speaking, as an athletic therapist, our bread and butter is exercise, because everyone who's an athletic therapist has a kinesiology degree. You can't say that for physicians or physiotherapists or chiropractors, but I was giving a talk yesterday and to kinesiology students at the University of Calgary, and they were asking about the differences between athletic therapy and physiotherapy and so on and so forth. And so I said our bread and butter is exercise. So it starts off with that, being an athlete growing up, going to York University and having to learn how to play sports you've never learned before, racket sports, swimming, gymnastics, ballroom dancing. Yes, that's an activity that we had to learn. And then learning how to break it down, like those complex movements of every sport into something a little bit smaller. So I use those as part of my treatment program whenever I see patients, and that usually comes first. But over the years, I've became more interested in manual therapy, which is where I met you, cranial sacral 1. I can't remember how long ago that was, 10 years ago. Cranial sacral therapy was one of the first ones I've done. So I use that with concussions. There's all these myofascial techniques similar to what massage therapists would use as well. So I use that as well when needed. And then recently I've stumbled upon more advanced techniques that changed the way I thought about injuries and wellness and so on and so forth. And it's how powerful the central nervous system is now. So instead of treating the muscles, you treat the nervous system, and the nervous system then tells the muscles to do something different. So that's been a very eye-opening experience set of coursework over the last 3-4 years. So nowadays, the patients that I see, I typically see those patients that are more complex, that have gone through athletic therapy, physiotherapy, chiropractics, and so on and so forth, and still haven't had success. So I get to see those patients now with which is a very more complex puzzle. And so it's a little bit of art and science, what's been done before, what hasn't worked, but let's look at it from a different perspective. So I've done a lot of the light palpation techniques, some of the more painful techniques like dig your elbow into someone's butt kind of thing, like and then they're squirming because it hurts so much. Those aggressive massages, myofascial techniques, which are a little bit gentler. And then now and more recently, some of those neurological techniques. But I still go back to exercise because that's what the essence of being an athletic therapist is.
So I'm super curious because I think that one time we went for coffee and we were talking about concussion-based therapies. And there was a little bit of time where it got really popular just because of all the sports injuries, and then it kind of went through this huge awareness on different social media sites and stuff like that. But obviously from a therapy standpoint, like would you say that cranial sacral therapy would help with that, or like some of the lighter touch, or have you noticed something that worked better than others?
The quick answer to that is no. And they're starting to discover this because pain science has evolved over the years. And this was what I was talking about yesterday to the University of Calgary students. The science of pain has evolved over the last, 1967 was the first big theory, Melzack and Wall, the gate control theory, in that research, and then evolved biopsychosocial model of pain. That was in the 70s. But right now in schools, the biopsychosocial model, which is a combination of biology, like the systems of the body working together, like brain tissue and nerve connections and stuff like that, that's 1/3 of that puzzle. The other two pieces have nothing to do with the body per se. The other third is psychological, which is memories, emotions, experiences, and so on. And then the social factor, which is people around you, mainly like your support structure, which has an influence on how you recover as well. So a lot of the concussion management strategies are based on these new models. There's also now the neuromatrix model that we talked about. But there's another model. It's not even a model yet. And that's kind of the weird thing about clinical practice and research, is they're not oftentimes aligned. You'll get these theories produced it's the opposite. You'll get these human experiences in a clinic with people, and you see the same patterns over time with different people. You start to pick out these patterns and consistencies, but the research behind it doesn't really take off until like decades later. And then they actually formulate a theory. And then 20 years after that, it eventually ends up in the textbooks, which doesn't discount the idea that biopsychosocial, that was something that was thought about 50 years ago, but now it's actually in the textbooks. So, but with concussions, the problem with concussions, and based on these new ideas of like chronic pain and these chronic injuries, is that how people respond to it is based on their previous experiences, and everyone's history is different. And there's different elements in someone's history that can impact how they respond to injury, concussion symptoms, and so on differently. So to go in with a hammer and assume each concussion is a nail and do exactly the same thing, I don't think we can do that. Like, I think you have to treat the individual because their histories and their past experiences and emotions are different. There are some nice little tools out there, but I don't think there's a one-all and be-all. I don't think there ever will be. So, yeah.
Well, I really like what you said about how, obviously every individual has such a unique background, and not just regarding their genetics and then any kind of predispositions in that, but then their experiences. And, how our environments, they really do either help us to thrive or it helps us to, in a sense, sink. When working with people and trying to get to know them from that personal level, how do you think, whether it's the physical therapist or the client, how can the two work together as a team to hopefully build some kind of a model that can get that person toward better health, better overall well-being? Like, is there certain questionnaires that is more likely and better to go through? Or is it more just based out of trial and error, you think?
Every assessment starts off with a conversation at the end of the day. When we teach students here interacting with the client, the most important part of the assessment process is the history. And so ever since I started taking these courses that talk about people's past experiences and emotions and all that stuff, my history as I teach it in class, I tell the students out of a 30-minute appointment, initial appointment with a client or patient, the history should take about 6 to 8 minutes. And then you have to do like your physical exam and exercise movements and so on and so forth. And that kind of builds your rehab program. But ever since I started taking these neurological courses and there's the biopsychosocial theories of pain and the emphasis on emotions, experiences, and memories, my history taking from Sport Icon is one full appointment, is an hour.
Wow. Just
sitting and talking for an hour. There are some standard questions you would ask, like where does it hurt, when did it happen, what kind of symptoms you have, and so on and so forth. But as a practitioner, I just let it evolve. A lot of times, if you sit and listen enough, they'll just share things with you that there's no medical questionnaire will ask. Like there's no question for it. They just tell you. And over the years, I've noticed that tends to be a lot more powerful than the standard physical exam. The physical pieces of an exam, like hitting your reflex, taking your blood pressure, sending for an x-ray, all those things are dictated upon the conversation that happens first. And it is kind of ironic that in the medical system, the healthcare system nowadays, typically when people go to a doctor's office, a lot of times the conversation is only 2 minutes. And patients are just like factoried through on a conveyor belt in these very, very short medical appointments when the history should be as in-depth as possible, especially if it's a repeat patient. They come back because whatever they've done before hasn't really worked. Someone's missing a key clue in the conversation, and so the history part is probably the most important before you even put your hands on them. So.
And now with the, and you mentioned this a few minutes ago, but the current research and where things are going with more of the nervous system. Can you talk a little bit more about that? Because I don't know if I asked you, and I really want to know.
Yeah, so the San Diego Pain Summit was just on in February. It goes on every year. It's in San Diego. Gonna go next year. Gotta come.
Nice. Okay.
It's all pain
Noted.
science. And so the trouble with concussion research and pain research is a lot of these things that the patient experiences is very difficult to measure. Like if you put your hand on a hot stove, for example, there's no device that measures the actual signal from your skin to your brain.
Right.
There are some machines that can look at how the electrical firing patterns in your brain respond to different emotions, to different pain sensations, and so on and so forth. But to actually see the signal go from your hand, up your arm, spinal cord to your brain, there's no device that can actually display that on a monitor. And so to say that pain is perceived because the brain's doing X, Y, and Z, that's one very small piece. That's kind of like the tip of the iceberg, what's happening under the surface of the water. Well, there's so many interconnections between the hand and the spinal cord, and then between the spinal cord and the brain that we don't even see yet. And so that's where a lot of the research needs to go. Whether it gets there or not, I think that depends on how fast technology advances. I remember as a kid reading something about Einstein, and this one article, it was at a Time magazine about dark energy, dark matter, and it's like everything that's around us. Einstein said it was there, nobody believed him, everybody thought he was kooky.
Yeah.
But it was because everybody thought he was kooky because no one else can see it.
Right.
He saw it and showed himself through mathematical equations, but now they've confirmed it years later because now we have tools that can see it and measure it. And so I think the same thing happens with observations that eventually become factual. They become factual when we're able to measure it, physically measure it and or see it. So when it comes to pain and like symptoms and treating patients, research related to the nervous system and how it works, I think is evolving. I think it'll really, really spike as soon as we come up with the technology to see some of these impulses, these nervous impulses, that come from your skin. They travel up your arm, hit your spinal cord. You can see it traveling up your neck into your brain and where it happens in your brain. And then the other piece of that is the brain sends out instructions for you to do stuff. And sometimes it's just reflexive. So to see those same electrical signals go from your brain down your neck back into your arm to pull your arm away from the hot stove, that'd be very cool to see. But we're not there yet.
Right.
So
that's so interesting. I love that stuff. Okay, so when clients come in, when they go through a few sessions with you, what are some of the maintenance strategies and different types of things that they can do day to day to be able to maintain proper function, proper movement, and a full broad range of practices?
I'd say the main thing is exercise. One of the key lectures that I watched from the San Diego Pain Summit was this woman that talked about exercise and its impact on chronic pain. And the more you exercise, and it could be any exercise, but it just has to be consistent. A single bout of exercise tends to make your body more sensitive to pain. So if your body's more attuned to pain, people will say, I can feel it more. And so they complain of pain. And then there's this bad cycle where if you have pain, you don't want to do anything. And then by not doing anything, you stay sedentary. And then as you stay more sedentary, your inflammatory processes spike. You feel more pain. It's just this weird cycle. Part of it is the sensation of pain and it continually growing. And then the other part of it is something called fear avoidance. That's part of the biopsychosocial model. Being afraid to do something because you expect there to be pain. So some of the things that I go through with patients who experience chronic pain is to get them moving as soon as possible. Even at like very, very low intense levels, just getting up and taking a walk every day. The exercise, according to this one speaker at the Pain Summit, basically said the more you exercise consistently, it doesn't have to be, it could be resistance training, it could be aerobic, it could be anything. There's some cells in your body called macrophages, and they tend to sensitize yourself to pain. But with exercise, they actually mutate. I didn't know this. This was something that was really cool to hear. Those macrophages actually change into a type of macrophage that facilitates pain inhibition. So the more you exercise, the more of these cells, the more of these mutations take place, which desensitize you to pain, so you feel pain less. And that's promising because you feel pain less, then that should be encouraging for people to move more. And then there's so many benefits to exercise. So exercise is always one of those main things I try to implement. The thing people have to be careful about is too much exercise, because then that leads to non-compliance. If you give people too much homework, they don't do it.
Yeah.
I mean, from an instructor standpoint, from a therapist standpoint, same idea. You give too much stuff to do, the people are just like, and then they don't end up doing it. So trying to find that balance between something that people like to do, because compliance is based off of, you'd rather do it if it's fun.
Right.
So and so that's where these programs are personalized. So exercise is always in that. Motivation, a huge part of the biopsychosocial model, getting people motivated, intrinsically motivated to do something good for them, even though it might be hard to get started. Sometimes I do manual therapy, sometimes I don't. To go in as a patient into a therapy session and have the same thing done to you time and time again, exactly the same program with no change, is the definition of insanity, right? Like you're doing something the same thing with expecting there to be change, but there's no change. Why are you still doing that when there's no if the outcome is still the same? So every appointment to me is new. It's different. Tell me what happened before, how you responded. We might have to change things, or we need to adjust as needed. And so sometimes I do hands-on, sometimes I don't. Sometimes I use a physical modality like ultrasound or an electrical stimulation machine. Sometimes use that, but only if needed. I don't just throw it on just cause. There are some clinics that operate that way, but that's not the way I practice. So it's always a combination of different things. I try not to use one tool only on one patient. There's always some benefit to using a variety of tools. So, but it all comes down to what that individual needs.
So I know that there's many different layers of pain, and most being in that area, especially in older age of acute, before it gets to chronic, which hopefully we're trying to do everything we can to keep them away from that level of going into that threshold. But those people that are in that area of acute pain, do you think with like the new science and information that's getting revealed with like even that cell that's able to change and mutate, do you think that that individual can actually, with a lifestyle change and with enough consistency, get themselves out of that loop altogether?
Yeah. Oh, of course. Like the sooner you manage it, the better. Always. Like it's those weekend warriors and those troopers that are like, oh, I can just walk it off, and then they don't think and do anything about it for like weeks and weeks and weeks and weeks and weeks. There are little things you can do so that you don't end up in that cycle. I know there's been controversy about ice and like icing injuries and so on and so forth. There's a lot of myth busters out there that purport that ice doesn't actually work. They would even cite, the person who discovered ice and putting it on injuries, they even say don't do it and so on. But they're misunderstanding the context of the conversation. So when something initially happens and you have inflammation, like you sprain your wrist and there's swelling and it feels hot and whatnot, managing that inflammation is key. So within the first 24 to 40 hours, putting ice on it right away, simply just to manage the inflammation, would make the healing process and the prevention of chronic pain far more likely. So it's always best to manage it right when it happens within the first 24 to 48 hours, whether it be ice or whether it be some type of anti-inflammatory, even like ibuprofen, Tylenol. Do something right at the beginning. The modification or morphing of those cells from one type of macrophage to another, and the one that is that sensitizes you to pain, to where you feel pain a lot more. That macrophage stays in that state if there's inflammatory markers in the system. So the less inflammatory markers there are, the more likely that macrophage changes into a pain inhibiting one. So again, that all goes back to managing inflammation at the beginning. And that's locally with the injury. I'm not an expert in nutrition, but there are some foods that are said to be anti-inflammatory foods. I would totally be on board with suggesting that to patients as well. And then the last piece is the impact of the immune system as a whole, having a healthy immune system. And a lot of times that's influenced by stress in general. And again, everyone's stress levels obviously go up and down with their day, with their life and whatnot, but having coping strategies for stress, I think, is really, really powerful. Working as an athletic therapist for the physical and some other elements of wellness is a good start. But if there are people that are stuck in chronic pain, sometimes seeing someone that deals with the mental side, a psychiatrist, psychologist, counselor, sometimes in those instances, if the chronic pain has, if there was an attempt to treat it over a long period, like years, and the pain is still there, maybe it's a psychological thing where referring that person to a psychologist, psychiatrist, or a counselor would actually be more beneficial to their physical pain. So.
I love that. You gave so much amazing information.
Well, it's not free.
No, it's not. And I mean, it's been so many years of hard work and study that actually got you to this point and experience with clients. So I very much appreciate your time. So with the last couple of minutes, is there anything that you want to kind of conclude with or come full circle with?
Yeah, I mean, for the folks out there who are listening to this, if you do have chronic pain and you've tried all sorts of different things, the techniques that I've used more recently for other patients that have gone through a barrage of different practitioners and different treatments and still haven't found success. There's only about 4 or 5 of us that have taken that course in Calgary. Myself, the person that I work with, that I share my clinic with, she does it as well, and a few other people. So if you ever want to have a conversation, I oftentimes just do a 15-minute consultation that's free, just to have a conversation about it, because there's so many layers to chronic pain that, to come in and just, help me is kind of hard to do. It always starts with a conversation. So I offer that for a 15-minute consultation if people are curious about it. But otherwise, I do the traditional low back pain, knee pain, and so on and so forth. Anyone interested in the athletic therapy program, you're always welcome to come and have a tour. We oftentimes give tours to the high school students here as well that are in the sport medicine programs. But outside of that, if anybody wants to eat, grab a burger. I'm a fan of burgers and wings. Definitely helps from the stress standpoint in managing chronic pain for me. So
totally, there's that balance.
Yeah.
So I'll make sure that I put all that information for individuals that are interested. It'll be just in the below description section. Still not used to this thing. So thank you so much, Dr. Valdez, and thank you everybody for tuning in and watching. Till next time.